This conference will now be recorded.
Hello, everyone. It's Tuesday, August 27th, 2024. Welcome to the AnCan virtual support meeting for high-risk, recurrent, and advanced prostate cancer. Thank you all for joining. I'm moderator Ben Nathanson, and I'm joined by moderators Len Sierra, John Antonucci, and Rick Davis, the founder of AnCan. We'll be taking up medical issues tonight, but nothing anyone tells you is to be taken as medical advice. That's what your doctor is for. Funding for this meeting comes in part from companies that believe in our work and have provided sponsorships. They know they can't buy our love, but they still fund us. We thank Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Helix, and Bohr Diagnostics. So we have a new guy tonight. Please bear with me. I have a new guy script. Here we go.
Ben, can we just mention the benefit of our new gent in case he doesn't know, wasn't aware, and hasn't seen one of our reminders yet? We do record these meetings because they go on to YouTube. There's around 300 people, between 200 and 300 people every week who some of the people present rewatch and other people just tune in. If you're at all uncomfortable, feel free to change your name or to shut off your video, but that's how we work. So sorry if we didn't tell you before we switched on. Our bad.
So, Darren, welcome. Appreciate you coming. I'll ask a few questions and then the floor will be yours for your questions. You actually answered this for Rick. For the purposes of the recording, where do you live?
I live in the Bronx, Riverdale, New York.
And you, again, for the second time, how old are you?
I'm 50 years old.
When was your prostate cancer diagnosed?
A month ago,
Wow.
July 20 something.
And what was your PSA?
The last time it was taken, it was 8.83.
Not too high. So what was your initial treatment?
So I'm in the not treated stage.
Right.
I'm
Right.
researching. Basically, had an MRI done, and let me know. I have no idea how to handle it, so I'm just going to ramble. Direct me if I'm going somewhere not productive. So I had an MRI in June after getting my PSA checked. It was 4.5, and then I saw a urologist. A month later, it was closer to 5. Had the MRI, came back with a couple of lesions that were pyrad 4, and then I had a biopsy like a few weeks later, confirming the diagnosis of lesions, Gleason's. Like, I mean, they're 4.3. Today, I just had a meeting with a surgeon at Sloan, Dr. Ladone, who said it was more like 7.5. I don't know what that means exactly, but and in any case, the MRI was misread. The original MRI was misread, and it was seen to be in the gland entirely. And then Sloan read it and saw some extracapsular extension as well as potential seminal vesicle involvement, invasion. And so I'm kind of still a little bit in the zone of trying to decide what is the best method of attack. And I know this is like high risk, but also recurrent and advanced. So I don't know if it's 100% appropriate. I jumped in, but again, let me know if if this is not the place to be. But I'm just, it's been kind of an overwhelming month, and I'm just trying to gather as much information as possible to make what the best decision. I am BRCA2 positive, so there is a level of concern about the aggressiveness of the cancer. So I got a couple gasps, so I guess that's a.
Well,
just so you know, I'm 4+3 as well. I'm BRCA2, and it's been 14 years that I've had it. So you may have a long life.
All right. I like hearing it. The first article I read said like 2 years median survival after diagnosis with BRCA2. So I was like, that's not great. But I didn't see who interjected there. Who was the?
well, it was likely me, because we have a separate email list which we'll get you onto, called BRCA Brothers at AnCan.org. And that's because we have a number of folks who are, I'm assuming your BRCA is germline, meaning it's inherited?
I would only assume so. My mom and my brother were tested negative. My dad died a couple of years ago. He never had cancer. Well, he had basal cell carcinoma, but he did not have cancer, and so I don't know if he had it, but it would make the most sense. His dad had cancer and died when he was 54, I think.
How did they discover that you were BRCA positive?
So this is a source of immense frustration for me, because I took a 23andMe test about 7-8 years ago and was tested positive and just pretty much ignored it. I mean, I guess I associated it with breast cancer and did not mention it to my internist or anything. And so that when I found out I had cancer, that I kind of like got brought back to my forefront, and then I had a confirmatory myriad genetics test that confirmed it.
So if you did the myriad genetics test, then yes, that's confirmed. In other words, that because you can be BRCA positive two ways. You can be BRCA positive because you inherited the gene from either or very occasionally both parents, or you can be BRCA positive because you made the mutation yourself. Now, most of the guys that we have encountered here, but not all, have inherited the gene. Some of the guys who have more advanced cancer do make it themselves later in the disease process. And it isn't so relevant to you now in your treatment choice, but it can be very relevant to them later. But what it does is it steps you up a grade. So if you're already got SBI and some extracapular extension, you would definitely be considered high risk. What we generally will do is refer those men to centers of excellence, which we've done in the past. And in fact, one of our gents who we will connect you to in New Jersey, Sal, recently got operated on by Dr. Laudone. So he knows about AnCan. And he is a really good surgeon, choice of surgeon on the East Coast. On the West Coast, we try and get people over to Dr. Carroll at UCSF, because he has a real interest in men with a BRCA mutation. Many of those men that we've worked with come in with much lower disease. Some are 3+3, some are 3+4, but that if they've got the BRCA gene, they're not candidates for active surveillance, although you wouldn't have been in the first place. The fact that you found it is great. The other reason why it's of real interest to us is because we have a board member, advisory board member, and you'll find her on the advisory board. Her name is Dr. Pamela Munster, and she is the co-director of the UCSF Center for BRCA Research. And her partner in that, Alan Ashworth, is actually the guy who discovered BRCA2. He's now the president of the Cancer Research Center at UCSF. So the gasp was really that, because you're in the right place, because we do a lot of stuff, and we can connect you to many peers, not just, oh, I suppose I should be putting Marchie, you're not on that BRCA Brothers, are you?
I've never heard of it. No.
No. Okay.
By the way, I'm the one that mentioned 14 years, Jeff Markey, and I'm a 4+3. I didn't have it as badly as you to start, but don't listen to this 2-year stuff.
Yeah.
We can help. People here can help you get a lot longer than 2 years, let me tell you.
I hope so. I mean, I don't know if this is premature, but what was your treatment?
Well, I didn't find out until 2 years ago that I was BRCA2. My father died of it. My brother has it, and I'm the only one that's BRCA2 of them. But I had surgery first, and 3.5 years later, I had radiation, and 2.5 years later, I started drugs. And I've been on Lupron for 7 years. But and you may want to consider getting on an ADT. Well, they'll probably get you on one soon to stop your cancer from growing. And but treatment, I think you need to speak to Rick. Rick, is surgery more suggested for this with the extensions, or is radiation just as good?
I mean, first of all, with a gent of your age, Darren, surgery is usually the treatment of choice. And so, like I say, Dr. Laudon is definitely a good choice, and then he will direct you if you need more treatment. And we have a couple of people, there's a couple of docs that we particularly like. So if you do proceed with the surgery, then they'll figure out if you need anything more. And when you are ready for a medical oncologist, don't let them assign you one. Talk to us first, and we'll make sure you go to somebody we like, because there's at least a couple of docs there. But
this is very timely. So, because again, I just had my discussion with Ladone today, and it was extremely productive one. I've had a couple of other ones that I just like shocking the personalities you find, but
yeah, we get it.
Ladone was great, and when they, it is complicated by this extracapsular, which is a piece of information I just found out last week. Like I'd assumed, I'd been told that it was contained within the gland, no lymph node involvement, no bone involvement. The PET scan was generally clean. I had a PSMA PET scan, but there were a couple of things that had very low activity in the ribs. They are assuming benign,
right,
presently, but the issue is because he mentioned. I mean, I've been doing some research along the way, and this. I did notice a recent trial with Lynparza and being effective for patients with BRCA in substitution of a hormone therapy, and he suggested that there were some early stage trials going on that may involve a PARP inhibitor at the same time as surgery, or perhaps somehow, or possibly radiation if I go that
Yeah.
route. I am leaning the surgery. Just it feels like the most aggressive route to take, and hopefully, given my age, who knows the right one. It does seem like the stats say it's kind of 50-50, and if it's out of the prostate, which in terms of which is better, surgery first or radiation hormone therapy first. But at least this point, I'm on the calendar for surgery, and that's the direction we're headed. Now they set me up with a medical oncologist, Dr. Hamid, Anis Hamid. I know nothing about him,
Right.
and
Right.
so
So here's couple of things. First of all, I decline Hamid, and you have two choices here. Either, if it were me, I would ask for Dana Rathkopf, and DANARATHKOPF, Dana Rathkopf, and she's wonderful. She's very compassionate. She's very smart. The other choice, but he's not taking patients until October 1st, but you may be able to get away with that, is Chuck Ryan, Ryan, who I know very well. I think he'd be a really good person if you had BRCA for various reasons that I'll explain momentarily. And he just wrote me that you could probably book a appointment with him as of next week, September, or maybe today. But he says he's not taking, but he might take, and we could write to him and see if he'd consider seeing you beforehand. He was the former CEO of Prostate Cancer Foundation until about 6 or 8 months ago, and before that he was at the University of Minneapolis, and before that he was at UCSF, which is where I know him from. And he's a good guy, and he gets BRCA. And if it were me, I would want an experienced GU med onc. Now, the trials is a real interesting subject. If you send us the trial numbers, what I'd like to do is I'd like to ask Dr. Carroll his opinion, and I'd like to ask Dr. Munster her opinion. She's not really a prostate cancer doc. She's really a breast cancer oncologist, but she's a BRCA oncologist. And I think she'd be willing to give us, I know that Pamela would give us an opinion. It's a real hard one to know. There are issues. What we seem to see is that when men go on to a PARP inhibitor, there is a chance, excuse me, let me back up one. When men go on to treatment beyond the surgery, there is a chance that the BRCA mutation in its wild form, which means its natural form like you have, can actually revert and become normal again. And we've seen that happen. That happened to Len, although Len's wasn't germline. It's happened to one of our other former board members who was germline, and he reverted. And so the advice now is, if you're going to do a PARP inhibitor, do it early in the process, because that's where it's going to have the most impact, because you don't want to take a chance that you don't have the opportunity to use it. And that's research that, I mean, that was in the last GU ASCO, wasn't it, Ben? That we had that slide in our last GU ASCO. So there's reason to do, even if you have for successful surgery, if you know you've got germline, and the problem with germline is it's in every single cell in your body. So there's reason to do a PARP inhibitor, whichever one, and to get bang up for it early. I don't know what the trial is. I don't know if there's a control group, if they're giving some BRCA guys the Lynparza, the olaparib, and others not. But we'd like to think it through with you, because I think it's very valid. Let me throw this one out to some of the other guys in the group, especially the moderators.
Well, first, I would say that being that Darren is seeing that onset MSK, he's in pretty good hands. Wadone is good, as Rick said. Dr. Dana Rathkopf is also very good. And I would, before we start recommending things to you, which we shouldn't be doing anyway, let's hear what they have to say as your initial treatment regimen. I'm certain they'll say it's, Lynparza, but what they will combine it with, I'm not so sure. Did you say you were, what, Gleason 8? I wasn't sure.
7, but
7, okay.
yeah.
4 plus 3.
Closer to 8, or yeah, I guess he said 7.5. I don't know that was a thing, but that's what he said today.
Well, unfavorable intermediate risk, they would call that 4 plus 3.
Yeah, but it's 4 plus 3 with seminal vesicle invasion and
There was
possible extracapsular extension then.
Yeah,
Yep.
and there was cribriform morphology, and there was
Okay.
intraductal. So it had some of the scarier characteristics.
How many
Yeah.
of your biopsy cores were positive?
3 of 16.
Thank you.
It was on the right side only.
Hey, Rick, another side of the PARP inhibitor, I didn't know until 2 years ago. So I started off with Lupron, and it lasted for 3 years, and then abiraterone lasted for 2.5. I plus darolutamide, and I'm going to do a PARP inhibitor after darolutamide stops working. There's the other direction too. I don't understand. PARP inhibitor is really tough on your body. It's really screws up your white blood cells.
Yeah, but you see the risk, Jeff, is that some people will revert to wild type, and so then you don't have the opportunity to get the benefit of the PARP inhibitor, which is why they're now leaning towards giving it earlier.
Isn't that unusual though?
Well, not anymore. I mean, this is where it's going, and this is where the research going. It might have been unusual 3 or 4 years ago, but now they're moving to giving that PARP earlier. I mean, I'm not saying, and don't get me wrong, Len, and I'm not saying you should do a PARP inhibitor. What I am saying is, Darren, if that is the trial that's being offered to you, I understand why it's being offered to you, and we should help you unpack that trial in this group. I don't know, and we
I don't know
wouldn't
the
give
trial
you.
either. I don't think that Dr. Ladone knew either. He wanted to get me in with a medical oncologist as soon as possible to start pursuing that avenue. Right now, I made I got on his calendar for the 11th of September, which is obviously very soon. So doing anything in that time frame suggests, I'm not. And in fact, my appointment, even with Hamid, isn't until September 10th, which was the day before my.
Let me just see. I think I do know who Hamid is, and actually, I think he's pretty good. I think he's done a whole bunch of. Isn't he the guy that's done a whole bunch of research? And I think he did the PARP inhibitor research, didn't he, Len? Does that ring a bell with you?
What was the name?
Hamid. I think I do know who he is.
I want to interrupt for just a second to talk to Larry Schuler, who's a new guy who's here for the first time. Larry, you came in, so I'm sorry to say you came in a little too late. We have too many people signed up to speak for us to give you a turn, but we would very much like to if you could come next week.
Oh yeah, I was going to come in early this week. I wound up in the wrong room, wound up in the Schmidt
Ah,
room,
sorry
and
about that.
took me 15 minutes to get there, and then it took me another 10 minutes to get here because I'm not real familiar with Zoom. But I'm not quite ready to make a presentation of my history anyway. So next week would be
Okay, okay. Sorry to interrupt,
I
Rick.
I have a question for the moderators, really. I just did an MSK nomogram on Darren, but I really question whether that's an accurate way to predict the outcome of surgery because the nomogram can't account for the mutation or the
Exactly.
ECE or any of that stuff. So we should ignore it, don't you think? Or what do you think?
Well, I think it does give you ECE and SVI, if I remember correctly, but it doesn't give you the mutation. So
It
you
didn't ask me those things. So
didn't. I
no.
thought that was in there, but I
Well,
could be
maybe
wrong.
I'll do it over. I'll do it over again and see
But
if I missed
it
any
doesn't
questions.
account for the mutation, and that screws everything up.
Okay. Okay. Thank you. I'll just drop it.
Yeah. No,
What, I don't
Hamid
even know
isn't the.
what is a nomogram. I don't even know what that is.
Well, that's okay. You don't have to because we just dismissed it.
Okay.
I was
I
just
have
wondering, it's a predictor of outcome after surgery, but I didn't think it was valid, and I wanted to discuss it with the guys before we educated you about it.
Okay. Okay.
Larry, did you have a Larry Schuler?
yeah the nomograms are basically an engineering approach. You enter the graphs with your parameters, the ones that it pays attention to. If it doesn't pay attention to genes, they're irrelevant to the nomograph. But it tells you what the statistical outcomes of men who have had those parameters are. So
Mm-hmm.
it's a historical, it's a prediction based on historical data, but only that data which has been observed. So
Right,
it's a
but
fairly good predictor of your odds, but it's not definitive to any single patient.
right, but Larry, I chose my treatment back in 2007 based on the MSKCC nomogram, and we often recommend it. The problem is that when you've got a BRCA2 germline mutation, that distorts the results of the nomogram because
Absolutely.
they don't have a BRCA2 option to bring in. They don't have enough people to base any
Right. So
prediction on.
it's the old rule: garbage in, garbage out.
Right.
Even if you put good information in, if it's not paying attention to additional pieces of information like the genes,
I
then
just
it
ran it
doesn't
again,
apply.
and I didn't get a chance to put those items in. So I
Okay,
think
There's
so
no place to put them in.
let's just leave the nomogram to one side right now because I don't think it's
Yeah.
relevant to Darren's situation. Um, there's discussion going on in the chat amongst the moderators as to whether um, radiation is an appropriate option. David Muslin, you want to just voice that since you have your hand up?
Sure, sure. So Darren, I was also a 4+3, and I was not as fortunate as you are because I didn't have AnCan to help me make a decision on the onset, and I chose a prostatectomy, and mine was far enough along that it was probably out of the gland as well. But had I known it was out of the gland, I would have gone right to radiation because, especially at your age, it really affects your sex life. A prostatectomy does, and you're young enough where you've got quite a few years in front of you, and you got a beautiful wife there. So you might want to think about radiation
as well, because you may get there anyway. I ended up having a prostatectomy, and within 3 months, my PSA started to rise again. Then I had to go to radiation anyway. So the prostatectomy was like worthless, and it really had a big impact on my sex life.
Yeah. No, thank you for that information. It's clearly a factor that I'm considering. I mean, I think there was a very real chance, given the BRCA2 and given where the cancer is, that that at some point in the not too distant future after the surgery, that I'll be, needing that next mode of treatment. And in which case, what did the surgery give me, and was it worth, kind of the
Right.
risks associated with it? So
Right.
it's a tough decision. There's no, I
Yep.
don't think an easy
It
one,
is.
and I'm taking in everything and trying to figure out what's best. I mean, clearly there's a lot, and what I'm trying to not focus on, and is there's a lot of people who, like, love me and want it out, and like they think surgery is the best way to get it out. And so there is that kind of, and it's in my instinct too. It's like I want this out, and so there's just it's a possible equation and decision. And that, yeah, I'm going through it. And like I said, I mean, the thing that gave me some level of like, okay, maybe surgery is the way to go, uh, is that the rad onc at Sloan, who I saw first, Dr. Gutman, I don't know, people's familiar with him, but he said, I have a slight leaning towards surgery given your age and the profile of the cancer. And which to me, again, the people I had met up to that point, which wasn't Sloan, I could have told you what they were going to say. If it was a surgeon, they were going to say cut, and if it was a rad onc, they were going to say radiate. And the fact that he was more open to the idea of looking at this with surgery, even though he said statistically you're likely dealing with very similar outcomes in either case, and like you said, 30-40% chance, he told me, you're going to have to come back to me or someone like me down the line. That information's there, and I don't know. I mean, like,
No, it can make you it can make you crazy, and it's hard. So
yeah,
if I could go back and redo
yeah.
what I did back then, knowing what I know today, I would have gone straight to radiation. I would have kept my prostate, because intimacy is much easier with the prostate than it is without.
Now here's my question to you:
Yeah,
do you have? Because my understanding is that hormone therapy and radiation can cause, not right up front and not all at once, but over time can cause, similar issues and concerns, and also, have those kind of intimacy related issues to worry about eventually as well.
from what I know, and there's a lot of guys on here that are a lot smarter than I am, and that we've all been through it together. But you have a much bigger chance of having ED issues with a prostatectomy versus radiation. And when you get on hormone treatment, you're not going to have much of a desire anyway.
Right.
But it's okay. But your equipment will still work.
Yeah.
And
Well,
for a guy your age.
David, you may not, because not everybody loses their libido. There's about 10 to 15% of men who don't, but you may not.
Right.
And the likelihood is you're going to.
Right.
But
On hormone treatment, on hormone treatment is what Rick is referring to, Darren.
right. But let me just come back. So it's a real good decision. It's a decision. I was diagnosed at 56, so it was a decision that I also had to make. And the nomogram was really my guide, to be honest. But I didn't have the BRCA mutation. And I think that the BRCA mutation really changes everything. And I know from working previously with gents who have a germline BRCA mutation, that there is a leaning towards surgery when you have the BRCA mutation. But this is really why, did you say you don't have a trial in mind yet, but Laudon said there may be trials?
Yeah. He mentioned like I'm gonna start looking into that and
Okay, so I'll reach out. Let him look out, and I'll reach out to Dr. Carroll because he's always really, really helpful. Peter Carroll is probably one of the best, if not the best, urologists in the country, and he's at UCSF. And I'll write to Pamela tonight, and I'll see what she thinks and what her input is. Oh, and by the way, there's a gentleman joined who's one of your landsmen here. Dr. Jeff, we've got somebody from Riverdale on here. I don't know if you can see Dr. Jeff. He just waved to you. But
I did. I noticed.
Yes.
I saw him out my window.
Okay.
Hey, by the way, with Trimix, even if there's a thing called Trimix, it's an injection you have to give yourself, but it allows you to get an erection even if you've had surgery. So there is a solution to that. You can't wait too long. You don't want to wait a year or two, but Trimix allows you to still have
let's go step by step. We'll cover all of this with you. We'll cover it in the under 60s group. We have an under 60s group. We'll cover it in the men speaking freely group, and we'll get to all of it for you. There are still 3 guys with their hand up, so I think we should do 2 things, Ben. One is, Darren, please, have you signed up for AnCan yet? Have you signed up, given us your email?
I don't know if I've done anything.
Okay.
Yeah.
Put your email in the chat.
Okay.
And you can either send it to everybody or you can send it just to me if you would prefer. We will sign you up so you get reminders. That's the first thing. So please do that right now so we know how to get hold of you. And I know how to get hold of you so I can give you feedback from Dr. Carroll and Dr. Munster. Perfect. And we've got 3 gents who want to talk to you, and then I think you're right, Ben, we got to move on, unless anybody else, any of the Brains Trust has anything to say about the BRCA situation.
Steve Rue, your hand is up.
Well, I just wanted to share with Darren my experience and the choice I made between the surgery or the radiation, because my doctor, my urologist, he was telling me the options, and it sounded to me like the best option was surgery, and that's kind of where I was leaning towards before I saw my radiation oncologist. The urologist told me that if I chose radiation, that I couldn't go back later to have the prostate surgically removed, whatever might be left of it, at a future date. But after visiting with my radiation oncologist, she, very sharp gal, very super smart, and she told me that was the opposite, that was untrue. That if I should have problems in the future, that they could go back and do the surgery to remove, I guess they call it salvage, some kind of salvage surgery or something. But when my urologist was telling me about the issues that I might face with the damage to the nerve bundles, all the attachments to the problems I might have there, I chose the radiation, and I felt today I feel very comfortable that I made the right decision. Ironically, the same week I told my brother I had prostate surgery, he got tested. He had prostate surgery. His was fully contained in the prostate. There was nothing coming out of it like mine, and he chose the surgery, and he chose that because he believed that was the right course for him, and he's still having some issues that I don't have today, and I just want to throw that out there. to carefully consider both options. That's all I'm saying. Thanks.
Thank you.
Thanks, Steve. I know your name is not Lou, but that's but it,
It's
what would you like,
Jeremy.
Jeremy? What
Hi
would you
there.
like to say?
Yeah, I just want to add, and Darren, I have a similar situation. I had a similar situation as you, 4+3. I did not have the BRCA mutation. I did have extracapsular involvement. I saw both the urologist surgeon and the rad onc. The rad onc had, because of my age, said, you know what? I think I would get the surgery first. And I ended up doing the surgery, and I'm back. But interestingly enough, and thanks to AnCan, Rick insisted on making sure I got my pathology report, which for some reason my surgeons were reluctant to hand over so easily. I got the pathology report, and it showed that I had positive margin in the left bladder neck, and I and so that's one issue. Two, I just want to thank AnCan so much because they have not been judgmental at all. They'd recommend that I look into radiation. And I'll be honest, I'm not saying that the outcome would have been any difference because I'm dealing with recurrence now, Darren. That I think if I had done the radiation might have very well have taken care of the bladder net issue that I'm having now, 3 years later. And the one thing my urologist didn't tell me, I was on pads for about a year, and I had shrinkage, literally because they resect, that section of the prostate out, which is about the size of a walnut, which is 3/4 of an inch to an inch, as you know. And when they cut that much out, your urethra is retracted that much. They never told me this.
Right.
I have read
You
that.
should have watched Jeremy. You should have watched Seinfeld.
Okay. But Darren, I just wanted to tell. I know it's a hard decision. I know at least for me, and I think for many people is, cut it out, get it out, is sort of the old standard. But I can just tell you, after having been educated and given the kind of information that AnCan has provided, the advances in non-surgical treatment have been far and great, and the precision of the machines is quite incredible. And I think you should, I'm not telling you which one to do. I just want to tell you what my experience was as well. And again, Len and Rick and everybody from AnCan, I can't thank you guys enough. Again, I mean, seriously, you guys have been a true blessing. Thank you so much.
So I see we have a couple of hands up, but also we have a lot of men who want to speak tonight. So if the people who have their hands up, if it's okay with them, I mean, speak up if you have an urgent thing to add. Otherwise, I'm going to move on to the next person.
And can I just give close out, come back on
Oh,
something I
please.
said
Yes.
before,
Yes.
and then I'm sorry, guys. If it's real important, then put it in the chat and put it in the chat for Darren and communicate through the chat. The guy that I was thinking of was Abida, not Hamid, Wasim Abida. So
Right.
I don't know this guy, Hamid. And I just looked again through all the names. I still would stick on our original suggestion. Go see Dana Rathkopf. Tell her you're an AnCan guy. She knows us well. Or try and get in to see Chuck, as one of his first patients. He won't have a big patient load when he first comes in here. He's very, very experienced. And he knows a lot about BRCA. He's worked alongside Pamela Munster. So if he's got BRCA questions, he can reach out to Pamela. He can reach out to Peter Carroll because he was their colleagues. But that's, I think, where I would go with that right now. But I would just, if it were me, I'd postpone the Hamid. Larry Fish, does Ortio have any experience with BRCA? Has that ever come up with you? Audio? Where's Larry Fish
Yeah.
gone? Where are you?
Right here.
No.
I don't know. I didn't never discuss rock with her, but I mean, I never discussed her experience with rock. I know she has a lot of patients and works with Ryan.
Okay.
They're like partners in all the research they're doing, but I don't
Right.
know.
Okay.
I know there's a lot of interchange between breast cancer and prostate cancer situations.
Right. So,
Mostly.
you know,
So
the
I
other
don't
thing
know.
that I can do, the other thing I can do for you is I can ask. Pamela used to work at Memorial Sloan Kettering several years ago, and I can ask her who she would consider to be the best the best BRCA oncologist. Because there may be some people in that list that are doing BRCA research that I don't know about, but she's going to know them because she's like one of the leading BRCA people in the whole country. So I can check with her and see who she may say Hamid. That's maybe why he sent you there. I don't know. But if I was just looking at them across the board, I would say Rathkoff or Ryan. Now, the other thing that I really think that you might want to consider and go back to Gutman and talk to him is that they have this new equipment at Memorial Sloan Kettering for radiation, where they do it in bore. So they radiate you inside an MRI machine. The guy who was one of the leading developers was across the street at Weill Cornell, and he's just moved over to Memorial Sloan Kettering to become the chief radiation oncologist there. His name escapes me for the second. I think it begins with an R. I'd have to ask one of our other guys for his name. But you do want to make sure that you talk to them about the possibility of that as another option. But I tend to think that the consensus is going to be surgery, and I don't know why, but I just think with BRCA guys, they feel that that's the best way to go, and I don't know why.
We better help Ben get this thing moving a little bit, I think.
Okay.
By the way, there was a guy that came in that was 26 years in with BRCA2. About a year ago, he came in. I don't know if you remember his name, but that really gave me some positive thoughts. That somebody who was 26 years with BRCA2.
Well, hopefully I'll be here at 76. And I thank you, Rick, for reaching out to those doctors and getting back to me with any information. I'm trying to be a sponge at this point. I want to move forward and start doing something because this has kind of been interminable and feels awful, like knowing that you have something trying to kill you and you want to do something. So anyways, thank you so much. And I know I've taken way too much of the time of the meeting, but I appreciate everyone for their thoughts and advice. I'm glad that I found this.
Yeah, we're glad you came too. You realize you have barely scratched the surface. We talked to you for an hour and you barely know what we know. So there's a lot more where this came from.
Yeah,
We're
I'm
glad
gonna
you
be
came.
listening.
Yeah. So, Mark Valens, you were here first. What would you like to share?
Just briefly, see if you get any feedback, if anybody has any ideas. I was on Xtandi for a long time, and I really didn't like it. And I heard all these wonderful things of all you people taking darolutamide. So I tried it. I only lasted 2.5 weeks. Um, and but I went back and looked through. There's a lot of other things going on in those 2.5 weeks, including I had nephrostomy tubes removed, and anyways, I ran it by my local med onc, and she says, let's go ahead and just try the darolutamide again. Stop the Xtandi, take the darolutamide, and we know what happened last time. If it happens again, we just stop it right away. I just wonder if anybody has any warnings or any thoughts about that.
I think it's a great idea because, as we told you before, Mark, we've never heard of anybody having that kind of reaction to darolutamide. So I wouldn't be at all surprised if there are other factors that cause those symptoms.
So cross my fingers. Hopefully I'll join all you happy people.
You know,
You don't have to
I
take the whole,
go ahead,
Rick.
Dr. John.
I'm just going to say you don't have to take the whole dose on the first day.
Okay.
You could, see if you tolerate one pill for a couple of days, and then just to make sure it's not a bad reaction.
Okay.
Go ahead, Rick.
Thanks.
So, I'm looking at my notes here, Mark, and I put having huge issues, fatigue, pain, confusion from the daro, and then I put dash could be kidney issue. So I don't want to say that's what I thought, but I do have it in my notes just in case. And that was my first, the reason being that we've worked with a lot of people in different groups with not just with prostate cancer, where they have UTIs and kidney issues. It results in a lot of confusion and fatigue, and it really messes them up. And a lot of those symptoms you were talking about sounded like a severe UTI or some sort of kidney infection. So I think it's a fantastic idea, and more power to your local doc for trying it. Funnily enough, it came up recently in my discussions with Bayer, and they've never really gotten back to us on anything on that. And we promised Dr. Puja faithfully that we would report all adverse events, and she insisted we put it in our reminder and everywhere else, which is why you see adverse events, because Bayer made it a bloody condition of their sponsorship. But there's nothing wrong with it. But I think it's a great idea, and we all wish you lots and lots of luck in switching over to it, and you'll have all this. You'll get rid of the confusion. You'll be going through your crossword puzzles in 30 seconds, and your Sudoku and everything else.
Well, I'll report back to you guys over the next week or two.
Okay.
Thank you.
Thanks, Mark. Next up is Dan from Alexandria.
Great. Darren, my situation might be something you might want to listen to. The only difference is I don't have the BRCA, but I was diagnosed in January with a 4+3. PSA went from 6 up to 15, and I was all set to do the surgery. An older gentleman, a friend of mine, had it done years ago and recommended it. And my younger brother-in-law, who ran in his family, he had it out, and his 3 daughters told him take it out because radiation and it'll always come back. So I was all set until I got to this group. And luckily through this group, especially Rick and Jim Marshall, et cetera, I started reading the books about surgery is not the way. I'm currently at 2.5 weeks into radiation therapy with Abby and prednisone, and into radiation therapy also, and almost past halfway done with the IMRT. I have 2 sessions of SBRT later on, and I'm going to do another MRI on Thursday.
but I didn't hear anybody talk about whether you should get the PMSA test, which really was a big significant thing I picked up from this group. Once I did that, my original urologist backed off. He was ready to do the surgery. And when they found out that there was 1 or 2 cells, cancerous cells beyond it, it was confirmed that they'd have, even if they took it out, they'd have to come back with radiation. So that's currently where I am. I have a little bit of the hot flashes, etc. But the big thing for me is I just had the blood testing done last week. My PSA went from 15 down to 10. It's now at 2. So I know this is all good for me, but there's nothing in there with BRCA. I don't have that, but it might give you some understanding of, if you didn't have the BRCA, how you might look at things.
Appreciate that. Just real quick,
I have to report.
I did have the PSMA PET scan,
Ah.
And it came back mostly clear. There are something in my rib that was very low level of lighting up that they are calling benign, but they can't guarantee anything. So that's kind of the current status of that. But that's congratulations and thank you for sharing that.
That's all I have, Ben.
Okay, Dan. Yeah, ribs are typical, as I'm sure they told you, they're just noise in most PSMA PET scans. Alan C., you're next. No more Alan C.?
Yeah, I want to know if anybody in the group has any experience with salvage cryo or salvage brachy for a recurrent Gleason 9 where there is no evidence of metastatic extension.
Any takers?
Salvage after what? After prostatectomy?
No, I had radiation plus Firmagon. And there was a recurrence still within the prostate. We treated it with initially Orgovyx. Orgovyx couldn't bring it down to non-detectable. Then we moved to Xtandi, and now my doctor is suggesting we stop the Xtandi and look for local therapy to try for a long-term durable remission. So he's recommending I consult for cryo or radiation. That would be brachy, high-dose brachy. Anyone have a similar experience?
I think it's going to be hard to find someone, Alan, because it's such an unusual situation that you're that you're dealing with. Most people, it's rare to see the disease come back in the gland. Most times it's outside the gland. And as we know, you've been dealing with the gland, with the disease in the gland for the longest time, and now they tried to, and there's no evidence that it's gotten outside of the gland in your case. And the enzalutamide, were you on ADT or just enzalutamide?
When are you talking about initially, or afterwards?
When they gave you enzalutamide to try and address what was in the prostate gland recently, did they also give you an LHRH drug?
No, because the Orgovyx exacerbated my diabetes and went sky high.
Okay, so they wanted to give it to you, but you had comorbidities, so they didn't.
Right. So it became monotherapy.
Yeah, I mean, it's very interesting because we were talking before about Dr. Munster. Dr. Munster has some research going on right now where they are putting enzalutamide in a capsule and placing it inside the gland to see how effective it is. So essentially, they're using it as as topical. Again, I don't know whether that could be used in your case, but since I've got to write to her anyway, I'd be willing to ask her if there was an opportunity to use this. It's in trial at NIH, but the trial's a little bit different. But I don't know whether you would be a candidate to place the enzalutamide right inside the gland. This is a possible future way to deal with prostate cancer, especially low risk.
Well, I'm a Gleason 9, so I'm high risk.
I got it, but we're talking about yours particular situation, right? I'm talking about somebody who, uh, never mind. Um, do we have anybody who's done cryo for salvage? We've had a few people. They're not on tonight. We've done plenty. We've got plenty of people who have done RT and a few who have done radiation to follow up on radiation. But I can look and see if I can connect you to anybody, but I can't think of anyone off the top of my head. I mean, you're not going to I don't think you're going to find a situation similar to yours. I mean, have you ever found anybody who's had a situation similar to yours?
I searched. I couldn't find anybody that was similar. That's why I'm reaching out to see if anybody knows.
Yeah, I mean it's really unusual. Where are you still seeing Gainesman or not?
Yes.
And what does Gainesman want to do next?
Well, it's his recommendation. I stop the Xtandi and then do the cryo or brachy once the PSA starts to rise, and we'll do a biopsy, to target it and what have you, and then try to eradicate it that way.
Sure would make sense. Sure would make sense. But yeah, I mean, we know Gainesman pretty well. I mean, if Pamela was willing to make this encapsulated enzalutamide available to you, because that would be a very benign treatment. It goes into some plastic capsule which they've developed, which disintegrates over a long period of time. And if Gainesman was on board, it might be a real interesting N equals 1 trial. And do you want me to check with her or not?
Sure, I'm looking for any options that are available. So with that option, I presume I wouldn't have the side effects because it would be localized just to the prostate.
Well, that's the concept. That's what we think. Do we know? No, that's why it's in trial. But the idea is that it isn't systemic. So you don't get all the side effects of enzalutamide when you put it into your whole system.
Right, because
Exactly
I have a
right.
lot of side effects. That's the reason, one of the reasons Gynecman wants me to stop and try local therapy.
Anyone else got anything on this?
I have a comment. Is the tumor localized and well defined? In that case, I would think cryotherapy or brachytherapy or any of those highly targeted ablation methods would be worth trying, as well as the capsulized enzalutamide.
Yes, There were two visible tumors, one on each side, from the get-go. They were there before treatment, and they're still there after treatment.
So they present a good target.
Hopefully, because the recent PSMA scan shows that on and off, they were still there, and one of them was shown they were expanding. That was before I went on Orgovyx. Then they showed that they were shrinking, but then after Orgovyx, they were expanding again, but still within the prostate capsule.
Yeah, so take your sniper rifle and go for them.
And any comments on which one has lesser side effects, the brachy or the cryo? I've been told that since I've had radiation, the brachy may cause catastrophic consequences because of the dose I had already, then plus the higher dose additional.
Yeah, I mean, again, I don't think we can judge that because anybody here who had brachytherapy didn't have it to a treated prostate. So we can't compare. So our experience is just not relevant to treating a to brachytherapy on a treated prostate. And I think the same, most of the case would be the same also for cryo.
I've read a report recently of good results from using steam instead of cryo. The steam penetrates into the cells and stops pretty much at the cell wall. So it's a little bit better targeting than the cryo. So that's something to ask about.
You know the name of the modality?
I can't remember it. My own therapy has really trashed my short-term memory.
So is that, are you thinking about the high frequency ultrasound or Tulsa Pro?
No. It's actually injection of steam, which
Steam?
the release, when the water condenses, that releases enough heat energy to cook the tumor. And it
So this is a
but
development.
stops pretty much at the cell wall.
Yeah, this is a development of Resume, which is a BPH treatment, which they've been using steam for quite some time, and now they're trying to use it. And now they're trying to use it for focal, but again, I haven't read that it's being used for salvage focal. It may be, and maybe Mr. Schuler is aware that it is being used for salvage focal, but I don't know that it's being used for salvage focal.
The study that I read did not refer to it as salvage, only primary treatment.
So, I think you're best to go with directed therapy.
Yep.
Which the cryo, I don't know how directed the cryo is. The high dose brachytherapy is exceptionally directed because they can put the rod in exactly where the tumor is.
Well, the radiologist indicated that we're going to treat the whole gland either way. They weren't going to just target the tumor. So it would be the entire gland.
Okay.
And I'm not sure about the cryo. I think they're probably going to do the same thing for the cryo because it is Gleason 9.
I think we should move on, Ben.
Yeah, my feeling is whatever they tell you, I would ask another doctor. This is a little because it's so uncommon. I would want to get a second opinion, whatever your current doctor recommends. So next up is Chuck Snyder.
Hi guys. So I just wanted, let's see, I've been on Pluvicto 4 doses of Pluvicto. I completed the last dose in April, last April, and after the 4th dose, PSA became undetectable. So I've been on a break up till now. I've been off the Pluvicto, and today I just had another blood test, and I'm still undetectable. So I'm going to continue to stay off the medication until my PSA starts to go up. So I'm really happy about that. But I guess my main question is, I've been on Xgeva for bone strength for a year and a half. About a year and a half. And I've been getting a monthly injection. And I recall a few months ago, I think Len was discussing getting off of the Xgeva because that's not supposed to be good long term. Is that correct?
Yeah, that's right. I'm getting feedback. That's right, Chuck. But at just a year and a half, you're okay for the time being. They don't like to go beyond 4 or 5 years with Xgeva because the incidence of ONJ, osteonecrosis of the jaw, increases with each year following, the 4th or 5th year. And so what I had done, and after reading a paper and showing it to my oncologist, is that I stopped the Xgeva and I had a one-time infusion of
Zometa.
Thank you, Rick. And supposedly that locks in the gains that you've made while you were on Xgeva. Because if you just stop Xgeva and you don't do anything else, the gains that you made will start slowly disappearing in terms of bone strength, slowly disappearing over the next year. It happens fairly rapidly.
Okay.
Yeah.
Okay. So
if you like, I can send that paper to you.
Yeah, that'd be great.
Well, although you're, like I said, a year and a half on Xgeva, you're good for a few more years.
Okay, good,
Yeah.
good. And then another question I asked my oncologist was, I've been taking the Xgeva monthly. Is that really necessary? Because all of my cancers in my lymph nodes. When I first got diagnosed 6 years ago, I had, a couple of lesions on my spine, which I had filled with kyphoplasty, and I had some other scattered lesions. But I've been on the ADT for 6 years, and there's no trace of any bone metastases anywhere. So I told that to the doctor, and he said, well, maybe you could reduce your dose down to every 3 months for the Xgeva rather than monthly. I'm not sure if is that a good idea or.
Yeah, that's a more common practice now.
Oh, it is.
Every 3 months, yeah.
All right. Okay. I'll do that then. Reduce it down. All right. Thank you.
Gary Peters, did you have a comment?
A question for Len. Len, does that upper limit also apply to Prolia?
I believe it does, Gary, although Prolia is half the dose of Xgeva and it's given only once every 6 months. So it's probably less of a danger of ONJ with Prolia, although I'm sure it does exist, just less likely.
Thanks.
Okay.
Rick, your hand is up. You really need it to be up?
Yes. I just wanted to check with Chuck. So Chuck, you did decide to stop after just 4 treatments of Pluvicto, correct? Because I know you're having a bunch of side effects and God knows what.
Yeah, yeah. I was. They weren't really bad, but ever since the PSA went undetectable, we didn't think it was any need to continue it until it starts to go up. So, but it's been since April and it's still 0.08. So I'm pretty.
But that, I mean, you're looking very tanned and healthy there in central New Jersey or wherever you are.
Thank you.
So, I mean, it's great to see you looking that well. And I just want to point out to Darren that Chuck, you were diagnosed at what, 53, 54?
56.
56. Okay. Okay.
Yeah.
So, okay.
Yeah. The chemo. I went through 10 rounds of chemo, and I having much. The minute I stopped it, the PSA just skyrocketed. So I'm having so much better luck with a Pluvicto. So I'm just so happy. I hope it remains this way for a while.
We hope so. And there are people now, and we've got a couple of them who have been through more than one round of Pluvicto, with time apart when they've instead of doing chemo again, they've done Pluvicto again.
Yeah. Yeah, and I asked my oncologist, once I finish the 6 rounds, can I continue? And he told me the insurance company only pays for six doses. Is that true? I didn't realize that. No.
No, they only pay for 6 doses per session. But if you if you were to come back with a recurrence, I think there's a very good likelihood that, well, we've seen it with other people where the insurance does pay for another 6 doses in another session on the basis of recurrence, but not very often because this is all breaking ground, man. This is all breaking ground, and I think that if that happened in your case and the insurance company gave you a hard time, we'd go back to Novartis, to our peeps at Novartis, and say, hey, what can we do here with the insurance company? And we'd bring Novartis into it. Fortunately, the lady who is now running that area is a good friend of ours. She was with us, and then she went off and did something else, and then the other lady left, executive director, and they brought Rachel Levine back, and we love her, and she really cares. And I think we would advocate that insurance companies have to pay for recurrent treatment, but there isn't a lot out there on it. I mean, Ben, Len, Dr. John, do we know anything more about treating a second time with radionuclides?
We did have was it Al Latimer? Somebody in our group had at least 2.
Al Latimer.
Yeah.
I thought we had one person too. I don't remember who.
Al Latimer. Len's exactly right. Yes, it was. That's who in my mind that I know he did. And I think there might have been one other person, but I'd have to look and see what my notes say.
All right. Okay. Well, thank you. Thank you for the advice. Appreciate it.
So Steve Rue, you're next.
Well, I just wanted to give you guys a quick update of where I'm at. As Rick and some of you others know, because of a recommendation, I saw a new medical oncologist down in Detroit, Dr. Heath. and she got me on the Orgovyx and the abiraterone. So I was very happy with that new procedure and regiment. She referred me though to her protege, who's a doctor that's closer. Instead of a 4-hour drive, it's just a 1-hour drive up here to Petoskey, Michigan. So Dr. Fadak saw me for the first time. I guess it was early July, and I had been complaining about some hip pain I had in my left hip. My primary care physician just, he thought it was some kind of osteoporosis maybe, or bursitis or whatever, but he didn't do any tests. Well, when I mentioned it to Dr. Fadak, Caleb Fadak, he said that we should probably do a bone scan. So Carmenos is part of the McLaren health system, and I'm sure you guys are aware of the problems that were going around with the new Windows security update from back in July, and it affected McLaren systems. So I've got I got the bone scan results back, and it shows that I'm clear, no metastasis to the bones, but we still can't find the CT scan. Trying to get my Orgovyx refilled, prescription refills, was a real big challenge, and for a couple of weeks I was very nervous because all of their computer systems were down. And when I know more about the CT scan, I'll let you know. But those people at McLaren and at Carmenos are serious angels. They were working with number 2 pencils and manila folders stacked up high on the desk, and it was insane. And although I was getting aggravated about trying to fill my Abby and my Orgovyx, I concluded that there were people waiting in line trying to get chemo and other things, and they couldn't get that done either. So anyhow, that's where I am with that right now. No bone metastasis, but we still don't know about the CT scan. I'm doing very well. The abiraterone and the Orgovyx was a damn good combination for me, and I'm doing well. My PSA is still undetectable. And all those fine people at the Carmenos Center in Petoskey got a dozen donuts delivered tomorrow morning. So my way of saying thanks. That's all I had.
Well, I am planning to finally introduce myself to Dr. Heath because she's going to be at PCRI, and I'm really looking forward to meeting her in person. I'm going to mention you to her and tell her that she made you a very happy camper.
She did.
And I mean, we love her. She's really, everybody we've ever sent to her seems to really relate to her well. I think Steve L, are you still with us? Aren't you seeing Dr. Heath as well?
No, I'm seeing Dr. Yevsky in Seattle.
Oh, that's right. Sorry. Sometimes I get confused. But anyway, it happens. Anyway, what I wanted to say to you was, I'm very glad you like Dr. Fadak, because the word that I've gotten is that Dr. Heath isn't going to be at Carmenos much longer. What?
No.
The word that I've got is she's going over to Mayo in Rochester.
Oh.
Yes. So I don't know if that's true, but apparently it is public information. Otherwise, I wouldn't have given it out, because the person who told me said it's public information. And I was concerned for Steve Rue when I heard that about a week and a half ago. But if Dr. Fadak is one of her proteges and he's closer to you, he's always going to be able to pick up the telephone to her and say, what do I do?
Yep.
And so I think that's really good, because I was really worried. Oh, who are we going to send? I mean, Carmenos has lost a couple of people since I've been working with them. Dr. Vyampian, who's now at Michigan, and now Dr. Heath. But they seem to keep coming up with really good medical oncologists. So we'll see who comes in next. And now we can refer to Dr. Fadak for people, provided they're not actually in the Detroit metro area. You might want to ask, you could do a little research for us, Steve, and if and when you hear that Dr. Heath is leaving, find out who the #1 GU med-onc is going to be in the Detroit area.
Good idea.
Thank
I can
you.
do that. I can do that.
Thank you.
We have spies everywhere.
Yes. Yes.
So Kurt, you are next.
Just a super quick update. Quarterly PSA test still. Oh, I'm sorry. Quick update. Quarterly PSA test still undetectable, and now my testosterone has risen to a whopping 200. So,
Right.
all good news.
All right. That's good. Do you feel a difference yet, Kurt?
No. But I just got back from a month in Eastern Europe and picked up a spot of COVID on the way back. So, I'm still recovering from that. So who knows?
Were you fortunate enough to visit Romania or not?
Yes, Romania, Hungary, and Austria.
Okay, well, I have the T-shirt for spending almost 5 years living in Bucharest. So.
Oh, okay. Bucharest was not my favorite city.
Nor mine.
Yeah.
How did you get on with those Romanians? Did they drive you nuts?
No, we were mostly with the Hungarian Romanians, so not the Romanian Romanians. So
the Hungarian Romanians are a different breed altogether.
Yep.
Completely different, and they're great, and they're warm, and the Latin Romanians, the Romanian Romanians, you got to be careful.
Yep.
Check your pockets all the time.
Yeah.
Rick, can I briefly ask what you're doing for 5 years in Bucharest?
Oh, that's a long story. I don't have time to get into that. We got too many people, but I'd be happy to tell you at some other time. But I was there for originally with the joint. I went originally for the joint, and then went out on my own, and we created a food bank and other stuff. But I'll tell you another time.
Okay, Rick.
So incredibly, unless my bookkeeping's messed up, we are through all our names.
No.
Is there anybody who wanted to speak whom I did not? Jeff. Okay.
Jeff Marchi. Well, yes, go ahead.
Well, I was more of I ran into a guy who has had radiation, and 9 months later, his PSA is 3.57, just went up to 3.75. And I've just never heard of anybody having that high a PSA after 9 months from radiation. And I said, boy, I'd be wanting a PET scan if I were you. But is this something that happens, that people still retain this high PSA for a long time, even after having radiation?
So I can tell you what happened to my brother, who started with a PSA of 30.
Yeah, he started with 11.
And my brother took something like 3 years for his PSA to finally, it's now something like 2.5.
Wow.
Every month was a little bit lower than the month before, and every month kept improving and improving for almost 3 years.
Wow. Okay.
So radiation is slow.
Thank you.
If we've got 20 minutes, we could return to Mr. Schuler if you'd like to do that, Ben.
Is there anybody else? Larry Fish, who came in later, Brian Jarvis, Dr. Jeff, Bruce, caller 2.
I just wanted to add one quick thing for Darren. You may not have seen that email this week, but before your doctor starts his procedure on you, make sure he's got his hearing aids in.
I'm glad somebody reads what I write.
I do. I love it.
Right. I'll send Darren. Darren, I'll send you this week's reminder. I'm just making a note on my thing, send reminder. I'll send you this week's reminder so you can see what we're talking about.
All right.
Wasn't there anyone else in the operating room at that time? The whole story is a little fishy.
Well, no, because Len, it was a colonoscopy. And, when I've had a colonoscopy, you're just there with the doc. They put you in a little side room, but there's no one. It's not really even an operating room with a colonoscopy.
Well, they should have an anesthesiologist at least.
Yeah. I was out for mine.
I was not out for mine. I was in Twilight Zone.
Oh,
yeah. Well, if they use
right.
propofol, that will probably require an anesthesiologist, although other specialists are getting their hands on propofol lately.
Well, if he knows sign language, that's one thing, but his hands are busy, so he's not going to help.
Oh, boy. Well, I try to put stuff in those reminders that at least will make some of you guys smile, because there's some serious stuff in there, but there's also there's some stuff that just catches my eye that I think, oh, this is just crazy stuff, and I slip that in every once in a while if I can find something that will get a laugh. So I'm glad it did. Bruce, are you new to this group? You're muted right now.
Yeah, I've not exactly. I've been on and off tuning in with the group just to listen to what's going on. I do have a question. I've been on Zytiga for about 4 years now. And my nuclear medicine scan was totally clear. And that's the second one 2 years ago. It was clear. My PSA has been non-detect for going on 3 years. And so my oncologist suggested now might be a time I might want to take a holiday. So I'm just going to stop the Zytiga, continue my prednisone for about a week. Anybody have any experience? Do you go through puberty again, or what happens?
So 2 things. Excuse me for jumping in, Ben, but I'd love Dennis Correa to address that one, because he's our resident expert on that situation. And 2, our recommendation would be to take a heck of a lot longer than a week to get off that prednisone, or else you're going to feel absolutely horrible.
Oh, okay.
Whose idea was the week?
That was mine. Okay, well, that's what I just suggested, and I got back. He said, well, he didn't see any other precautions. So I appreciate that comment as well. I'm not taking the Lupron at all. That I dropped. I was on that for 1 year, dropped it, and I've been taking only the Zytiga now for at least about 3 years. So, and he said the half-life on the Zytiga would be fairly short, much shorter than the Leuprolide.
Bruce, forgive me for asking, and if you want to just put it in the chat window, but I have several Bruces. What's your last name?
Oh, Bondo, Bondow.
No, I don't have.
Oh,
I don't know whether.
B.
I don't. No,
But
I don't think we've ever done an intake on you. So as a new man, but that's
okay.
okay. But Dennis, do you want to? You've been through this one.
Yeah, I could share a little bit. What dose of the Zytiga were you on?
1,000 milligrams a day.
Okay. Uh, well, there is another option if you want to go to a lower dose, but mostly you can get the same effect with only taking one tablet. Uh, that's the 250 milligrams with a low fat, low calorie meal.
He's going to ditch it altogether, Dennis.
Yeah. Oh, I'm just saying that I know. Just give him another option that he might
Oh,
be
I
interested.
see. Yes,
But
yes.
yeah,
Thank
you
you.
can't get off of it. And the prednisone, you probably want to get your doctor to give you a weaning schedule to wean off. What level you're on there?
I'm on 5.
Yeah, that's okay. That's pretty low. That wouldn't be too hard to wean off of.
Okay.
But
But you think
yeah,
maybe,
you gradually reduce the dose down over a period of time, just so you don't have any bad effects from that. And
all
then
right.
the other thing, when you decide to do this, talk to your doctor about number one, monitoring. You're going to continue monitoring quarterly. We'll do the blood work and
Oh,
so
yeah,
on.
definitely.
Yeah, and also at what point decide when the PSA starts to go up. Your next step is going to be to get a PSMA PET CT
Yes.
scan to see what's going on, and
Mm-hmm.
just get into an agreement with your doctor. Some of them are different in what they want. Some will say 0.2, some will say 2.
Okay.
Uh,
All
and
right.
when you get to that point, but have a plan so when it does start to come up, sometimes you could switch from that quarterly blood work to a monthly blood work, just so it can rise pretty rapidly once it goes up. So if you do it every month,
Aha,
there's
okay.
a chance of it getting too far beyond where you want it to be, and get you a PET CT scan,
I'd like to
PSMA
ask,
PET
Okay.
CT.
can I ask a question, because I don't know your history, so I can't quite follow what's happening. Were you metastatic to
Okay.
begin with or non-metastatic?
Yes, I started out with a PSA of 85, metastatic to the lymph nodes and a spot on my spine.
Okay.
So I just started on Luprolide and the Zytiga together. And I've been
So
on that now since March of 2020.
can I suggest, Bruce, that you come back at the start of a meeting, because we
Yeah.
try
Yeah.
to get all the new people and anybody who wants to ask a question in the first 10 minutes of a meeting, and then we can plan out the whole meeting. And since we don't have notes on you, we'll do an intake with you like we did with Darren today, and Larry Schuler. So just
Yeah.
come in any meeting next week, or the week, the meeting on Labor Day or the following week, and we'll just do a complete intake on you,
All
because
right.
it,
Well,
it would be
appreciate that.
good
Yeah,
to,
I do know the protocol. So,
yeah, yeah, yeah.
all right. Thank you.
Dr. Jeff, you had something you wanted to say, I think maybe about the prednisone, and so did Jim Marshall.
Yeah, I would strongly recommend, even though you're only on 5 milligrams a day, to have your internist sit with you, because a week is really way too short. Even 5, it's way too short. You may need to be on 2.5 for weeks and weeks and weeks, and then cut it down and monitor your blood pressure and your potassium, serum potassium.
Yeah.
You don't want to wind up with Addison's disease as a
Mm-hmm.
result of stopping it. And one quick question: what made you stop the Lupron?
Oh, that was the recommendation of my oncologist who had just done a study at the University of Minnesota.
So you were on Lupron for like 2 years, and then they stopped and just Abby.
Yeah, just 1 year I was on.
1 year. Stopped the
Right.
Lupron and continued the abiraterone.
Correct.
Who is your oncologist? Was it Chuck Ryan?
No, I started out with Dr. Rao at the University of Minnesota, and he left and took a position at Baylor University. And now I'm seeing Dr. Jha, Jha.
Okay. I mean, the reason I asked if it was Dr. Ryan, because I know even when he was a PCF, he was still seeing patients there, is because he's basically the original principal investigator for abiraterone. So that would have been very interesting if he would have recommended. But yeah, he's Dr. Abiraterone, Chuck Ryan.
Okay.
Jim, did you want to say anything more about prednisone?
Yes. Anyway, I did the same thing. I was on it for 5 years and I cut it off. I did the 2.5 for 10 days. I did the 2.5 then, I believe, every other day for 10 days, and then every third day for 10 days. And then I was done. And I have been on a holiday now for just past 2 years. Okay, abiraterone and Lupron. And the PSA is just starting to recover barely, 0.03 for 4 months now.
Okay, that's encouraging.
And it's been nice to be off of it, except I still get occasionally the hot flashes, even though I have been off of things for 2 years. Occasionally,
Well,
it's back.
Captain Jim, that's what happens when you have a younger wife.
That's right. Oh, Bruce, are you a veteran?
Yes. I am not.
Oh, okay. I was just curious.
Jim, what is your testosterone level?
Now it has just reached 409. It was a slow climb. And in fact, testosterone took about 14 months to start to climb. And it climbed slowly.
And you were on Lupron or Orgovyx?
Yes, I was on Lupron plus the Abby for 5 years.
And you were metastatic to begin with or not?
Yes, I was, all the way up within the lymph nodes and the back, and were the two big ones. And a Gleason 3-4, 2 nodes, but seminal vesicle invasion, no.
Congratulations, you're doing well.
Well, I think one of the best things is, I mean, with what Captain Jim didn't tell us is he just turned 80, so a testosterone level of 409 at 80 deserves a few fireworks. I wish we could. Can somebody put a few fireworks in the chat window, please?
That's good.
All we've got is a hand clap from Steve Rue. I think we can do better than that. If I got to do it, Oh my gosh! But no, that's great. That's great, Jim. I mean, really, we're very proud of you. And again, sorry if we didn't get to people today. It's really important, and it is in the letter. Because the way AnCan trains its moderators, we know that the intake can take a while. We had the luxury of spending a little extra time with Darren today because we only had one newbie that we thought, And so when a newbie comes in later than that, it sort of screws us all up. And then the people who are regulars and have questions don't get time. So there's nothing personal against anybody, but that's the system that we've found best to work. So,
I understand.
okay. Okay. And now you guys are going to kill me because both Bruce and Larry are going to come in next week, and then we'll have all the questions, and then I'll be buried again as usual in the first week of the month. So, but we'll
We're
get through
saving
it.
everything. We're saving everything for next week for you.
That's right. That's right. And Larry Schuler, please do check. I think that Jim may have given you some links, but please check our links on estradiol and estrogen, estradiol, Wassersug, because there's a lot of information on our website. Dr. Wassersug did a special for us earlier this year with 5 or 6 guys who were on estradiol, and spent an hour and 20 minutes with them. So there's a lot of information there. We've discussed it many times in the groups. Richard was with us probably about 3 weeks ago and spent a lot of time talking about it because it always comes up when he's in the group, but we don't know when he's going to be here and he's not going to be here. So, at least you'll know, you'll have as much knowledge as we do if you go check all of those things.
I've been researching heavily since April of last year, and I've got a lot of information, including something that came up new, estradiol cypionate, as an intramuscular injection rather than transdermal.
Mm-hmm.
So I'm digging into that as well. But thanks. I will look for that. I didn't realize that you guys had that much information on estradiol.
Yeah, well, we've been working with Dr. Wassersug for many, many years, and he's on our advisory board, and every so often he attends the groups, and we always welcome him. And then he's done at least 2 webinars for us. One a long, long time ago, and then a recent one because we had about 6 or 7 guys that were very interested in estradiol therapy, and so he agreed to do a webinar for us, and that was 2 or 3 months ago. So just Google his name and you'll get a lot of information. And Dr. Jim, I put a Captain Jim, I put a firework in the chat window for you.
Thank you. I see him.
You sure that's not a jester's cap?
You're right. Yeah. Oh, Steve Bruce disappointed with it. Sorry. Oh, well, the thing is, I probably needed 3 of them, Steve, but it's too complicated to put 3 in on this chat window. They only allow you to put 1 in at a time.
Oh no, a sparkler fizzes out though, so I don't want sparklers.
Captain Jim never fizzes out. That we know. I will say, since we've got a second, if any of you are vets in here, we are moving the group as of September to when, Captain Jim, the vets group?
Shall be the first and third Tuesdays. Okay, at exactly 8 o'clock Eastern time within the Schmear room.
Right.
It's a different room. Okay, the first and third Tuesdays.
Right. And if any of you have, that group is not specific prostate cancer. It's all about getting your benefits, the most out of your benefits and your health care at the VA, which,
Well,
by the
VA,
way, Dr.
TRICARE for Life,
Right.
government sponsored health care. I do all of those.
Right.
So it's a range of everything.
Right, and Captain Jim, I just learned that you can get your dental, because when I came back across the line from getting my crown done a couple of Fridays ago, I said to the guy the border patrol agent, I said, I got a great dentist over there. He said, oh, I don't need that. I get my dental at the VA. So that's so I learned that you can get your dental work done at the VA too. So I don't know what they do there. Do they make dentures, or is it do they do more than that?
I believe they do, but that's for
Okay.
only if you are 90% or 100%, which I try to get folks to. In other
Right.
words, a lot of people say, well, I don't think I could. I say, well, let's explore this,
Right.
because
So
I have
And
found I can generally get you up there or
you,
close.
so you're looking at
yeah,
the wizard, the sparkler wizard of the VA here, the veteran sparkler wizard here. And if you have any friends, whatever their condition, like I say, it's for everybody and anybody, men and women. Send them to our VA group, vets group, because we're now going to be running it twice a week. That's because Captain Jim doesn't have enough to do since his open heart surgery.
Right.
So
but that's
let me just let
the
me
rating
let
per
me
minute, right?
let me just tell you guys, like, he's recovering from his open heart surgery. He's gasping there, and he's saying to me, "So when can we start the second group?" And I'm saying to him, "Get yourself well, and then we'll talk about a second group." So God bless him. He's well, and we're going to two groups, and we truly welcome. If you've got friends who are vets, please send them to that group. We will make a world of difference for them. And we've got a few guys in the group even tonight who attend that group.
Right.
And thank you, Jim.
Okay.
On the eligibility for dental, that last week, Jim, you said they had to be permanent, not temporary rating.
No, I believe it is 90% or 100%, or you have a dental
Service connected.
right service connected. So, but it's not that hard to get up, because let's put it this way, all of us who served, especially within the states now, you were exposed to a lot of hazardous materials, believe it or not. Here in the United States, in the post, they have finally discovered that, and I've got a lot of information on it. So,
Right. So let's not get too deep into
right.
dental. Come along to the first Tuesday in the Schmear room. We'll talk all about dental. Michael McCabe, this meeting started at 3 o'clock. We're about to finish. Okay, this is a Tuesday meeting and it starts, and you're lucky you found us. We're running over. And I have a question for Ted Kurtz. That's not a name I recognize. Are you also a new gent, Mr. Kurtz? Have you been in this group before? Mr. Kurtz. Well, he may have walked away. Well, we'll see if he comes back another time. But I think we're done, Mr. Nathanson.
Yes, on the subject of walking away. Good night, everybody. Thank you for
We'll
coming.
Good
move
night.
to adjourn. Thanks all.
Good
Thanks,
night,
Scott.
everybody.